Pulmonary complications can occur also. About 20% of patients will have symptomatic form. Mild oxygen impairment can be seen in about 80% of patients. These complications are associated with worse clinical grade and higher mortality. Patients may develop pulmonary edema. It can either be from cardiogenic or neurogenic causes. They may also develop acute lung injury or even ARDS. The mechanism is also related to a sympathetic hyperactivity or to the cardiac failure we already described. Neurogenic pulmonary edema typically is managed the same way as other forms of pulmonary edema, and when mechanical ventilation is needed, you want to avoid any hypercapnia, because that can elevate the ICP. So current recommendations, we want to get a baseline cardiac assessment with serial enzymes and EKG as well as an echo early on in the hospital course. We want to have vigilant fluid balance management should be the foundation of monitoring the intravascular volume status, and our goal should be euvolemia. We don't need to place a central line just for central venous pressure monitoring because it's found to be very highly inaccurate, and currently pulmonary artery catheters are no longer recommended to show benefit. So retrospective studies have identified a relationship between hypovolemia and increased incidence of cerebral infarcts and worsening outcome. And it appears that there is a defect in regulation of the intravascular volume following a subarachnoid hemorrhage that can actually result in hypovolemia. And our goal really then should always be, as I've mentioned, is euvolemia. Glucose control is also important. There was a study of subarachnoid hemorrhage patients treated with insulin infusion to maintain tight glucose control that found an increased episode of hypoglycemia. And in those patients, there was an associated with more vasospasm and a less favorable outcome at 3 months. Conversely, hyperglycemia also can be associated with the increased risk of vasospasm as well as a risk for infection. So the current recommendations are try glucose control to try and keep between 80 to 200. Now, we noted that Mr. B had a mild hyponatremia when he presented, and hyponatremia complicates the course of about a third of patients with subarachnoid hemorrhage, and it's associated with worse outcomes. It's believed to be secondary to a combination of the cerebral salt wasting and the SAADH picture. For these reasons, subarachnoid hemorrhage patients are administered isotonic fluids like 0.9 normal saline. Because hyponatremia can exacerbate cerebral edema, we are usually going to also start to treat early or very mild levels of hyponatremia. Hyponatremia should be treated with oral free water restrictions if they are taking PO. If not, and you would want to start with mild hypertonic fluids such as 1.5% or 2% or even 3%, and they can run as a continuous infusion. Sometimes we might use mineralocorticoids like Florinef or hydrocortisone, which may help with the diuresis and also reduce the hyponatremia. So current recommendations, isotonic crystalloids are the preferred agent for volume replacement. In patients with persistent negative fluid balance, the use of the mineralocorticoids can be considered. And during the period of risk for delayed cerebral ischemia, control of fever is desirable. With those that do have fever, you want to look for a source, but consider that there is an increase in inflammatory response in subarachnoid hemorrhage, and there may not be an infectious source. We want to utilize medications like acetaminophen and ibuprofen before we start utilizing more aggressive measures like surface cooling and intravascular cooled saline. In these particular cases, you're going to save this for when you feel like fever control is highly desirable. Maybe they have elevated ICP issues. So additional recommendations to consider: the use of unfractionated heparin for prophylaxis can be started 24 hours after undergoing surgery or an invasive procedure like an intraventricular drain. There's trends towards higher rates of intracerebral hemorrhage, though, with low molecular weight heparin. And both unfractionated and low molecular weight heparin should be withheld 24 hours before or after an intracranial procedure, including a ventriculostomy. So Mr. B actually did